IO access, important, of course, and a necessary skill, is certainly on our ALS level and higher, of course. But I predict at some point probably will actually become more of something that we may look for all providers to be able to provide as scope kind of broadens out. Rambling a little bit about it, but here's the deal. There are a bunch of blood vessels in your body, right? If you stripped everything down, we are a big part liquid, and a big part of that liquid resides in our blood vessels themselves. A larger part probably actually resides in the interstitium, but we have lots of blood circulating around lots of places where you could potentially get into the circulation in order to give things to it, like drugs, like fluid, anything like that. In order to get into it, though, we have to be a little bit specific because most of those blood vessels are pretty small and it's just not technically possible to get in a lot of places. So we typically use the IV route, which works most of the time, except when it doesn't. And when does it not? Well, if you look at different studies of pre-hospital IV access, they document the success rate anywhere between 43% and 91%. And that's overall. That's not like I stuck them the first time and I got it, but success rates from 43 to 91%. So a large kind of variation in there. So that means that less than half the time you could be getting an IV on your patients, and almost 9 or up to 9 out of 10 times you could be doing it. And it sort of depends on the situation and that sort of thing. I certainly understand that, but it is definitely something that is not consistent at best. And we've all had the frustration of like, man, I really want to give X medication, or I really want to do X, Y, or Z for this person, but I can't find an IV because they're old and dehydrated and I can't start it, or because they're an IV drug user and they've scarred down all their veins, or there's just nothing there, or this is a big old edematous person that I can't feel their anatomy for anything and can't find a site to establish that IV. These are certainly realities, may contribute to that number as well, but it's not certainly universal that the person is going to roll into the emergency department with an IV. That said, not everybody has to get an IV. Let's be perfectly honest. If you're not going to do something that's kind of life-saving and you can't find a place to do IV access, then a lot of the time it doesn't matter. The time when it does matter, though, they really need that. They really need that access. If you need to give them something, and you need, meaning like the person has a good likelihood of suffering morbidity or mortality if you don't, then you have to get access. We have a bunch of different ways we could do it. It could be a peripheral IV. We don't think about it very often, but the external jugular kind of sits right there and is in a lot of people is a nice target. If you're privileged or credentialed to do that, that works. But then we often kind of forget about the IO. We sort of think to ourselves, all right, definitely this is my go-to, and then, by this point I've tried 5 or 6 times, and it's a short trip to the hospital now. It wasn't when we started, but it's a short trip now, so I'll just wait till they get to the hospital. And we kind of seldom go on to these other access sites. I would challenge you that is probably the wrong thing to think. And I will tell you why in a second, but I will give the old inflammatory statement that if you need to give somebody something, if you need to give it, again, a cardiac medication, they're hypotensive and they need fluid for whatever reason, they're septic. If you have something that you actually need to give, then there's really not an excuse anymore to show up at the emergency department and just say, well, we would have given a 500 cc bolus of fluid because his blood pressure is 60 over palp, but we couldn't get an IV. There's not really an excuse to do that anymore. Maybe at one point, but not now, because you have other options. And the other option, of course, it's most familiar and that's easiest to us, although we don't actually use it as much as we should, is interosseous access. So an IO, just to hit the basics of it, how does it work? You have a cannula that sticks down through your soft tissue into the bone, through the cortex, and then into the medullary space in the bone itself. If you remember your bones, they're not entirely solid. They have a bunch of little, there's a hard cortex, the hard rim kind of around it, but just like, we're coming up on Thanksgiving, take a turkey leg and split that sucker in half, and you find that most of it is actually not quite empty space, but marrow. It's little trabeculae, it's little fibrinous type stuff. In there is a lot of blood. That's where your red blood cells get made, is in the marrow of your long bones. So you have a lot of little fine meshwork in there. You have veins that run in and out of your bone cortex itself. When you break a bone, you can get some significant bleeding from the bone itself. Likewise, if you get into the medullary space, you can aspirate blood back. This is a pretty big open area that is held open by that bony cortex. So no matter what you do, you have space inside your bones through which we can infuse blood or fluid or drugs. And it goes relatively quickly out of your bones through those little haversian canals, through those little bridging veins that went through the bony cortex that you saw there, and into your larger blood vessels, and then is taken from there, back into the central circulation, just like everything else. And this is the cross section of a tibia, just in case you were curious. If you wondered what it looks like when you actually put an IO needle into somebody's leg, that's what you're feeding into. So kind of a sponge-looking bony fibrinous network in there. Again, it always works because all of us have bones, usually, except for the one time when I remember reading a chart, thinking like, okay, they're gonna get an IO on this guy. Checked first leg, above the knee amputation. Check second leg, above the knee amputation. Looked at his arms, fractured humerus on one side, and dialysis port or dialysis graft on the other side occludes it. All right, fine. This guy, the one guy that you couldn't get IO access on, but everybody else that has bones, we are able to get vascular access on. Sorry, apologies for whoever I just let in. I didn't realize you were sitting there in the waiting room. And by the way, like I said, I'll be kind of flipping back and forth. Thank you all for coming. IOs. Right, there we are. Now you may ask yourself, how big is an IO catheter? Well, if you're curious, it is a 15-gauge bore, essentially. How does that line up with the other IVs that we might establish? It lines up right here between the orange and the gray catheters, which 14 and 16-gauge catheters are pretty big, right? You can infuse a lot of stuff through that. The difference is that for an IO, you're not really basing it on the size of the catheter itself, like the hole. What you are basing it on is where you are injecting into. So while most of us would be pretty happy with an 18 in most people, where an IO, humeral IO, and I'm using the long needle here to represent that, flushes at about the same rate, maybe a little bit higher, as an 18-gauge short peripheral IV. Not a big, long, like catheter, because the longer you make your catheter, the slower your flow rate actually is. But a humeral IO in an adult usually gives you a flow rate somewhere the same as an 18-gauge IV in the the antecubital fossa, which is pretty good. It gets a little bit less depending on what other sites you use. So if you're going down into the lower extremities, like you would if you're using the, doing a kid, or if you have a person that you're going to do a tibial IO, then your flow rate goes down to more like a 22 or a 24. The flow rate is not that high. It's still there. Now, if you have no other choice, a 22 is better than nothing. A 24 is better than nothing. And it's also not affected by, like, you can't, once you're in place, as long as you don't pull the thing out, it's not going to blow if you infuse too quickly or put something else in there. Fluid can extravasate if you messed it up a little bit, but for the most part, this is a pretty safe thing. Of course, we make a lot of big deals about the flow rate itself. Here's the question, though, does the flow rate actually matter? For most of the stuff we're going to do, it doesn't. So whether you have a 22 or a 24, if it's a good 22 or a good 24 that you can push stuff through in the pre-hospital setting, unless we're given a bunch of fluid, when you think about it, the flow rate is not really that big a deal. Most of the stuff we're going to do doesn't have to flow in at a high rate of speed unless it's fluid. So if you get 36 mLs per minute, what can you push over a minute? Well, that would be half an amp of bicarb. That's a pretty big amount of fluid, or a pretty big amount of stuff to be able to push through something in 1 minute. So the flow rate in and of itself, let's just call it adequate, pretty much any place you go. We can debate about it a little bit, but for the most part, for what we're doing generally, flow rates are pretty good, especially under pressure. That brings up the other question of what drugs can we actually put through this thing? And really the question is, what can you not push through it? And that's pretty much nothing. Essentially anything that you can push through an IV, you can probably get through an IO. Now, this is a big list of stuff that is in there. You see things as wacky as like calcium chloride, there's beryllium, there's paralytics. There are reports of people given, hypertonic saline, normal saline, red blood cells. You can all do it. Almost everything that you can give through an IV can go through an IO. The one time which I have seen it done, but it seems very difficult, pushing something viscous like D50. D50 pushing through an IO is going to be hard to do, but you shouldn't be using D50 anymore anyway, because we're all using D10, because D10 gives you better response and it's less of a hyperglycemic spike, and you do less bad things for people when you do it. And if it extravasates, it's no big deal. So use D10, and then it goes easily through an IV. You just put it on a pressure bag, or you put a blood pressure cuff around it, crank that sucker up, and you can flow glucose through your IO. I am shocked sometimes at the hypoglycemic people that are brought in. This is actually what prompted this talk. Gentlemen with hypoglycemia, known hypoglycemia, they tried the glucagon thing. It never works because the person's always, an old person or somewhat decrepit or something like that, and they just don't have stores of glucose to mobilize with the glucagon. Essentially unconscious, certainly not able to take PO. And they came into the emergency department still with their blood glucose. It was initially documented at like 25, and then it was 15 when they got to us. And the questions be like, you couldn't have done anything? Well, we couldn't get access on him. He's a hard stick. He's got bones. You can do it through bones. And I know you have D10. I digress. You can push pretty much anything through an IO catheter if you can get it to flow in there. So, let's do it. How do we do it? In case you haven't seen it before, but I'm sure you have, let's review the steps real quick. You got to pick a site first, and then you should cleanse that site probably. That's a good idea, because you don't want to drag a whole bunch of filth into the medullary space of your bone. That makes sense. You then take the IO needle, load it on the end of your driver, and I'm going to discuss the easy IO right here because that's what's commonly used out there. I know some people have the big IO, the thing that goes in your sternum, but I've never actually seen anybody use it or come in with it, but I'm sure somebody's got it out there. Anyway, for the easy IO, the most commonly used one, you load up the needle and then engage, or you insert the needle itself and the whole thing in through the soft tissue to the bony cortex and sort of engage it on the bony cortex. Now, we make a big point that you do have to be able to see that last black line on the needle in order to say that you've got enough space to drill into the bone. And why is that? Because when you engage the bone, you have to be able to get it through the cortex itself, and that last mark is 5 millimeters from the hub. If you can't see the last mark, that means there's too much soft tissue in the way, and you won't be able to actually get through the cortex. You may be able to, but not reliably. You won't be able to get through the cortex without running into a bunch of soft tissue. So if you can't see the black line, that means you need to find another space that has less soft tissue in the area, or you need a bigger needle. That's the description of why, and you can sort of see that demonstrated up here. You don't want to be like that guy at the bottom, because if you try to drill in at that point, the flub, on his anterior shoulder is just going to hold the needle out, and it won't work. So, insert through the skin, engage the bony cortex. Make sure you see the last line at least. You can see any other number of lines is fine, but you got to see at least one line. And then once you've engaged the bony cortex, we actually start the drill itself. So you start spinning it. It just goes at one speed, so give it a good squeeze. You don't have to put a whole lot of pressure on it, but you're sort of drilling, and then you'll get a give. And as soon as you get the give, you can stop. At that point, you've gone through into the medullary space itself. You unscrew the cap, the stylet in the center of the thing, and pull that out. You don't attach that to the... or don't leave that attached to the drill itself. We've seen people do that, and if you try to unscrew it with the drill, you end up dislodging the IO, so don't do that. But pull the stylet out, attach the stabilizer if you have that, if you haven't lost it, and then attach a primed extension tubing to the device itself, to the hub. You can secure the thing at that point, and you'll want to flush it. Now, the idea was, if you remember that picture that I showed you before of the medullary space of the bone, there's a bunch of like fibrinous tissue in there, and there's like marrow and stuff, and it's very complex or compact in there. And if you try to just like dribble in on top of it, it doesn't work very well. So what you actually got to do is take and flush real hard. And anybody who's done it before knows the amount of pressure that you have to apply to the thing, because what you're trying to do is kind of break apart that immediate fibrous space there. You got to force all those little particles out of the way, so that you can then create a little space where you can flow into, and then flow rates will work a lot better. Now, we're going to talk about that in just a second, about how incredibly painful that is and about what we can do about it. But that's about the worst part of it. If you've seen folks that get drilled, nobody really minds the drilling very much. It's not very painful, but that flush hurts like a mother. And that is probably one of the reasons that we don't do it very often in awake patients, but we could, and I'll show you why. Anyway, once you have flushed the thing with 10 cc's of fluid, it should be working pretty well. You can aspirate before you flush to show that you're getting some blood back or some marrow back if there's any question about it. Then you'll want to put fluids going with pressure. And again, why? Because there's just not a lot of space in there, and you have to really kind of force fluid into that medullary cavity. But when you do, then it actually works really well. If you don't believe me, here is a quick video. And this is the guys from EMRAP. I stole this off their YouTube channel. Thanks very much, folks. You don't realize that I'm doing this. Here they're engaging. They've got the bone itself. They're well seated on the bone. Here comes the drill. They hit just a little bit, or they got a change in resistance. They've stopped, pull the drill off, unscrew the thing, putting the little holding device on. And if you saw that, that's fairly well, tightly held in there. If it's not like fairly well seated, if it's rocking around, that probably means you're not in the right spot. So here, they're aspirating a little bit of marrow back. You see it coming up through that tube. Marrow and blood come back out of there. And they've got a successful IO access. Now, they haven't flushed it yet, but we'll hit to that in just a second. What they've proven so far is that they're in the medullary space and that they've done it right to everything we know of. Now, here comes the flush. They've got a 10 cc flush on there. And this will loop a couple of times here. One thing I want you to kind of keep an eye on, there was where they started flushing it right there. When it comes back around, look at the other guy's oops. Look at the leg here when they do the actual flush. I'm assuming that this is a more or less unconscious person based on the response, but watch right there. You see how they tighten up? That's probably my guess is that's probably the person posturing because it is incredibly painful. Flush, oh God. And if you've seen videos of folks when this happens, they all go, oh, and if you're awake, you about nearly syncopize. The awake IO flush is terrible. It goes on board with the joint challenge where we inject a bunch of saline into somebody's joint to see if it's still intact, and the chest tube, the awake chest tube, as one of the most brutal things I think we can do to folks. This is a really painful thing. This is like cancer bone kind of pain in terms of the scale of it, and you don't want people to have that impression of you because you are just trying to help them. There's something you can do about it, though, because the problem is that when you push all that fluid in there, it pushes on the inside of the bone and literally gives you like cancer-type bone pain as you're separating, putting pressure on the middle of all that medullary space in there. We can do this better. We can essentially anesthetize the bony space itself, and this is not something I know that typically outside, local anesthesia is kind of outside of the ALS scope in a lot of places. But this is different. What you're going to do here, in order to make this more palatable for folks, when we're talking about adults and kids, the dosing, I can't remember offhand, I think it's 0.05 mLs or 0.05 milligrams per kilo. I'd have to check on it. Adult dosing at least is easy, and kids kids are just kind of small adults, so divide by the size of the kid. Everybody over at Children's just lost their minds when I said that. But for adults, here's what you're going to do so that the person doesn't kill you and so that you aren't making this making the worst day of their life a little bit worse. You take 2 mLs of cardiac lidocaine, 2% lidocaine, what you have in your code card if you're still carrying lidocaine, and hopefully you are because it's not a bad drug, if for no other reason than this. Take 2 mLs of 2% lidocaine. You push it really slowly. Once you withdraw a little bit of marrow to show that you're in the right spot, instead of flushing hard at that point, you push really slowly and inject those 2 mLs of lidocaine into the bony space. That will avoid putting a whole lot of pressure. It's still going to be a little sore when you do that, but not nearly as bad as you pushing as hard as you can on it. So little sore, but that'll go away starting to go away in hopefully about 5-10 seconds or so. As you fill up the space with a couple of mLs of lidocaine, that will anesthetize it, and then you let it sit for 2 minutes. So 2 mLs of 2% lidocaine for 2 minutes, let that sit, and then you can push. You can flush after at that point. If the person's still having a lot of pain, you can actually do another half dose after that, so 1 mL. But 2 mLs of 2% lidocaine for 2 minutes will make this a lot easier. Most people can tolerate at that point, can tolerate it just fine. That also brings up, like, this is the patient that's awake, of course, or responsive, who you just haven't been able to get IO access or IV access on otherwise. But this will actually make it tolerable, and folks do tolerate giving drugs or fluids through the IO at that point, even when they are awake and conscious. But it does take a couple of minutes. Realistically, though, when you think about the amount of time that we spend, like, screwing around trying to get an IV, and like, oh, I can look at his hand, or I can look at, maybe he's got something back here. In the amount of time that we spend kind of messing around trying to get a peripheral in these guys, we would probably be better off, even though there's a 2, maybe 4 minute time where we can't do anything with it. If you think about how fast you can put in an IO, and everybody talks about how fast they put in an IO, if you think about how fast you can put in an IO, add on to that 2 minutes for the problem of having to let the lidocaine dwell in there. You're still at like 3 minutes for having good IV access, and that's appropriate. So there's really no reason time-wise that we can't take our time, do a quick IO, anesthetize the snot out of it, and then be given fluid. And it's, again, if you have to give something, I'm not saying do this on every kid that's vomiting and wants a little bit of Zofran, but if they're hypotensive, if they need a drug, if they need a medicine, if they need something, then do this. There's really no good reason not to do this if they need something from you. Let's talk where real quick, which is the crux of this whole thing, before we finish this little segment up. Where can you do it at? There are sites all across the body. They typically cite the proximal humerus, the proximal tibia, and the distal tibia. These are the ones where you usually think of in adults. And the proximal humerus has about, again, in adults, the best flow rate. It's a little harder to find if you're not practiced at it, but I think that's mostly because we don't practice it very much. It's actually not a hard thing to do. If you're looking for where you do the proximal humerus at, you're basically going to find the clavicle, find the acromion, excuse me, find the step off, and going laterally, as I've got my hand on my belly button right now, find the step off between the acromion and the proximal humerus itself. I basically put my finger in that step off, put another finger on top of it, and then maybe another finger right about there, and then rotate. I'm trying to show you how to do this. Rotate 2 fingers, and wherever the edge of those 2 fingers are, that's basically the humeral head. So again, one more time, I'm finding the acromion, I'm finding the step off, I'm putting 1 finger on the step off, putting another finger next to it, and depending on the size of the patient, maybe 1 more finger on top of that, but usually just 2 fingers. 1 finger breath down, rotate those fingers over, and wherever that ends up, that's essentially the humeral head right there, which is what you're going to be going for. When you do the drilling itself, you're going to go perpendicular to the bone, but aim for the other scapula, and that will get you in the right spot. Again, the humeral head is a relatively big thing. It's just a little bit harder to find in some folks, but you can do it. You just have to kind of get a little practiced at it. That works real well for adults. That's probably our number one place. Now, everybody goes proximal tibia. Why? Well, in kids, proximal tibia is maybe a better choice than humeral head because little kids are not always ossified up here, and so it's mostly cartilage, and there's growth plates and things, and like, I don't want to get into that. And it's harder to find, and it's smaller. Whereas the proximal tibia, we can all see that, right? It's the flat part of your bone just underneath your knee. How do you find that guy? My recommendation is the way I do it. I find the patella first. I sneak over and find the tibial plateau, which, by the way, is not always as easy to find. Usually the 2 bones actually fit together pretty tightly, so it's not like there's going to be this big space if the leg is straight. If you bend the leg ever so slightly, flex it at the knee, then that space will actually open up. You can keep your finger there and then straighten the leg out, and that'll tell you where the tibial plateau is. Anyway, to the tibial plateau, once I've found it, I'll go down maybe 2-3 centimeters, 2 fingers, thereabouts 3 centimeters, something like that, again, depending on the size of the person. Slide over to where the patellar tendon inserts onto the tibia itself, which is the tibial tuberosity, and find the flat part on the medial aspect next to that, and then drill into that part there. So again, I'm like, from the tibial plateau, I'm like 2, maybe 3 finger breaths down, find the middle of the bone, and then go to the medial aspect next to that, and that ends up in the tibial or proximal tibia itself. Now, there's another spot that we don't typically kind of do. I just redid all my thing here. Another spot we haven't kind of thought of. Again, in an adult, probably the proximal humerus is the best site if you can get it in there and keep it in there. Maybe a little bit more soft tissue that you have to contend with. Distal or proximal tibia sort of works. In kids, though, and in adults, one site that we could access, but we often don't, is the distal femur. So just instead of going south of the knee, go north of the knee. The anatomy looks something like that. You know, your femur is the biggest, strongest bone in your body, essentially. Makes a whole bunch of red cells, pretty vascular inside it. Where you're going to want to go is, again, just north of the knee, not into the knee itself, but above the condyles of the femur. It looks something like that if you had the knee flexed. So a little proximal up there. Now, the good news about most of these things is that if you hit a marrow space, like, it works. It doesn't have to be exactly 2 centimeters up. There's nothing magical about that. That's just a good place to start getting into the marrow space itself, and it keeps you away from the knee and like all the ligaments and that kind of stuff. If you had to go a little bit farther up, then that would be okay too. Looks something like this if we were going to do it. Again, on a person, I would find the patella. I'd slide over and find the medial condyle of the femur, which is going to be the big, kind of round bony part there. I'm going to slide about 2, again, maybe 3 finger breadths up from that medial condyle. Just make sure you're above it mostly. And then go a little bit medial to midline. Maybe put 1 finger on the midline and go just to the medial aspect of that, and you end up in more or less the right spot. Again, you're going perpendicular to the bony cortex itself when you drill in. It'll be just a little bit off to the midline. Now, one thing that's important is, who are you going to do this in? Everybody has a femur. Everybody has bone, or everybody has marrow space inside their femur. That's true. The problem is that in adults, they also have lots of stuff in their leg. They have big quads. They have lots of soft tissue sometimes. It can be fat. It can be other stuff. But for the most part, we've all got pretty big musculature in our thighs. And that makes it tough because you're not going to have a needle that is probably long enough to get in there in most adults. However, for kids, this works out pretty well. Why? Because kids don't have real developed quads. They're not real, generally speaking, they don't have real, like, kind of flubbly legs. And so even in a kid that's got relatively, this is my kid, by the way, I didn't do anything weird, at least as far as he knows. If you look at the proximal tibia, they've got these small little spaces. Maybe you try there and you fail for whatever reason. If you look up just a little higher, you can get distal femur. You really don't have to move anything. If you've prepped that area with like a ChloraPrep or something like that, then you're already good to go in that spot. The space is relatively easy to find right above that. And again, even this is one of my skinny kids. This one's a little bit chunkier, and even though he's small and he's got little, Stay Puft Marshmallow type legs, I can easily find his anatomy and pretty well guarantee you that one of those yellow needles, one of the long needles, will make it through his soft tissue with no problem. Now, the little red one, that's not going to do it, but the yellow one definitely will. I suspect the blue one might, but definitely the yellow needle would. And that would be fine to use. There's nothing that says that it couldn't. They're all the same bore size. It's just the length of it. There's nothing that says you can't do that in a kid. So it is a relatively easy thing to do if you need to give this kid something. And what might you need to give this kid? Benzos if he's seizing, glucose if he's hypoglycemic, fluid if he's septic, or if he needs some sort of cardiac drug, that drug. There's all kinds of stuff that we could give through there. Now, I do bring up one last thing, in that if you're making a lot of runs to nursing homes, you may find that you have some elderly patients who, for whatever reason or another, you don't want to try a proximal humerus. It is still possible to get a distal femur in these. Now, that's probably not following your protocol right now, because it's probably just spelled out that adults are proximal humerus, if that, but definitely proximal tibia. But you could do this if you have an old person with really skinny little legs, as many elderly folks are, especially if they're in a chronic nursing facility or something like that. These folks are going to be hard to get IV access on. They are going to have low amounts of muscle mass. And many of them are, when we pick them up because they're borderline unconscious to start with. This would be a reasonable thing to try. And again, how do you know if it's going to work? If you're in a pinch and you have to give some medicine, if you just load up the yellow needle on the end of the EZ-IO, if you insert it into the correct place, just because if you have that little black mark still outside the skin at that point, you could theoretically do that. Now, again, it's a little outside probably most protocols. The company is not going to tell you that you can do that, but could you do it? Yeah. If you're going to do it in the or in the proximal tibia, there's no reason you couldn't do it in the distal femur, at least from a medical kind of standpoint in these folks. The only thing that's really keeping you out of it is the amount of soft tissue that most adults have there. But skinny little lady who hasn't used her legs in 2 years, maybe it's an option. Again, if nothing else, it's something. It's another thing you can do to obviate the excuse, well, I would have given him 3 liters of fluid on this 2-hour transport, but I didn't have IV access. That's not going to cut it anymore, because we have ways that we can do this, and we have comfortable ways that we can do this. Do this for folks. So, to sum up this little section, if you need to give something, you have access somewhere in there. And again, this is not, it would be nice to give 500 cc's of fluid because she feels a little dehydrated or something like that. This is, I got to give this, or this person's about to die, or they're unconscious, or it is critical to this person's care. If you need to give it, then not having access is not really an option anymore. You have access somewhere. IO access is pretty much as good as an IV. It's a little bit harder to push stuff through, but it will work for pretty much anything you would use otherwise. Adults, you should use the proximal humerus if at all possible, which has better flow rates than the proximal tibia. In peds, consider the distal femur primarily rather than the proximal tibia in many cases, given that it's a little bit better flow rate and a little bit easier to actually get into when you start doing it. And then the proximal humerus, really just kind of in older kids and used with a little bit of trepidation. You don't see a lot of proximal humerus IOs, but you can certainly, again, attempt it in the child that is in extremis, that you've got to do something, and for some reason they don't have legs or other ways to access it. And then just remember, when you're going to do this, if the patient is awake or responsive in any way, aspirate first, don't flush. Take 2 cc's of 2% lidocaine, slowly inject it through your IO that's just been placed, and let it dwell for 2 minutes before you then pound in 10 cc's of saline, which is going to hurt like hell. 2 times 2 times 2, 2 milliliters of 2% lidocaine for 2 minutes, and this is an adult or an adult-sized person. All right, that's IO access in a semi-nutshell, and we haven't been going for too awful long here.